to our Unclenched podcast. Today, we're going to talk to Dr. Ben Sutter. Dr. Sutter will be chatting with us about diagnosis and a bunch of stuff. At the end of the podcast, we'll have a couple questions from you, our listeners. But before we get started, it's been a while. I got to catch up with Priya. What's happening with you, Priya?
All good things over here. Kids keep growing. They're 7 and 9 now, and it's just so funny because my 9-year-old daughter, 10 months ago, she started reading Harry Potter, and we watched one of the movies, and she was so scared we had to turn it off. And now all of a sudden she's like, "Can I watch Lord of the Rings?" And I'm like, "That is way scarier."
Yeah.
And she loves it.
Oh my
So I don't know.
goodness.
These kids you never know what you're going to get next. My son couldn't be less interested. We're watching Lord of the Rings. He's rolling around on the ground. He runs to another room, does a whole Lego, comes back. Like, they're just fun. They're just
Yeah.
fun. Yeah.
Yeah.
What about you? What's going on with you, your family? And then is there a patient that's been on your mind?
Yeah. So we just got back from Denver and visiting my one daughter, and my other daughter from New York flew out to be with us too. So we had a great time with like our core four, and it was just
Yeah.
fun. It's fun. It gets better and better. I mean, mine are a lot older than yours, but and I remember the 7 to 9 and kind of miss that, but I love where we are now.
Oh,
And they're just a barrel of fun.
yes.
But one of the things that patients that stuck out, especially since we're having Ben on, was a patient of mine. His name is John. And he was in before Christmas, and he was just horrific headaches, daily headaches every day, neck pain, not sleeping well. Um, I had so many of those signs and symptoms. And I thought, you know what? I think he's a good candidate for DTR, though we had to add a little bit to a canine, but I think we can get away with it. So I saw him a week later and he wasn't doing any better. I said, John, you hang in there because this is going to work. Your EMGs are looking better. Your disclusion time is looking a lot better, whatever. So I saw him now. And he said, Alex, I walked in at Christmas. My family could tell I was feeling better. I am so much better. And we still have a little bit of ways to go, but not much. But he's so happy. He's so satisfied. And I'm thinking, oh my gosh, thank you, Dr. Sutter, for teaching me all this. And it just makes you kind of sometimes just want to cry. I mean, I get emotional, I get emotional with my patients. I don't always get emotional about everything else, but when I suffered with pain myself, and then knowing what it did for me and to be able to help people is just like crazy.
Yeah.
Crazy. What about you, Priya? Any patients on your mind?
Well, again, I knew Dr. Sutter was going to be here, so I have a DTR patient, disclusion time reduction therapy, on my mind. Her name is Helen. She is the sweetest lady. So much stress in her life right now. She's taking care of her husband, and she's clenching all the time, and it was causing a lot of pain, constant pain. And after the first appointment, the pain wasn't constant anymore, but it would still come and go. After the second appointment, it was significantly better, but still some. And she just had her third appointment yesterday, but she's like, this has been amazing. Like, she's just so blown away. And so, DTR therapy is something that, compared to like how long you guys have been doing it, it's fairly new to me. I mean, I've been doing it a little over a year now, and it's really changed the way I practice. So I'm just so happy that we have Dr. Sutter on. So I think, let's take a deeper dive with him, and
Yeah.
welcome back, Dr. Sutter. It's so nice to see you again.
Thank you, ladies. It's great to be here. I'm glad you would accommodate me, and I'm happy to share this morning.
Well, we're happy to have you. So we want to get to business, and I've got some question for you. Like many suffering from TMD and TMJ, whatever you want to call it in your arena, are looking for answers. Some are newly diagnosed. Others have been searching across dentists, doctors, chiropractors, a bunch of other providers. And we get this a lot of questions on our Instagram and stuff like that. But is there a set of questions that you would tell patients, hey, you should ask the doctor and the practices these things like before you get to treatment or when you're there interviewing them? Because not all practitioners can treat like we treat. So how do they kind of quiz them to see what's what?
Well, I think, there's two types of patients that really come into our practices, respectively. There are patients who are at the beginning of their journey. Hey, I just Googled you. They don't know anything about you. They saw a
Right.
TMJ. They might have seen, some symptoms you had listed on your website. And they're like, okay, I'm going to go, kick the tires, so to speak. And then there's the other type of patient, which I think most of the three of us anyway are dealing with, and that's the people that have seen multiple providers. Hey, my dentist said he was going to make me a night guard. I hear that a lot, and of course, I always want them to bring that in. Yeah, I want to measure it. Let's see what they made you. A lot of times, it makes the patient worse, or they have no therapeutic effect, right? It's just a barrier between the top teeth to the bottom teeth. And so, it's interesting, and you run the gamut of, I don't know why I'm here. My doctor said I need to see you, to people who've printed out reams of paper.
Sure.
It's like, I read everything that you've published. Okay, well, that took a
Wow.
long time, number one. And then they have papers highlighted, right? And they're quoting me back to me. And so some of that is like, okay, well, let's put some context to what I said, because you're taking something that I said out of context and part of the bigger picture. But I thought it would be great for us to just kind of like, well, what are the things that I think could streamline and make a patient's visit to a consult more efficient, right? And so one of the top questions is, one of the things I want to know of my doctors, if I'm going in for a procedure or whatever, is like, well, how many times have you done this procedure?
Right.
How long have you been treating TMJ disorders? And you have to be your own advocate, right? So, if somebody is kind of blasé and says, oh, well, we've been doing this ever since I graduated dental school. Well, there should be some active content on either social media, their website, something in the reception area where you're waiting. If there's none of that, it's akin to walking into a cosmetic dental office and there being no pictures on the wall. It's like, well, wait a minute. How do you set yourself apart from everybody else?
Right.
And you have to be careful with any response that you're given, right? You have to take it into a little bit of context. Context is always important when answering these questions. And what I mean by that is, if, there's still people that believe the world is flat. And we've known for a long time that it's not.
It's flat, Ben. I don't know what you're talking about.
It certainly looks that way, right? And it's a good illustration from, like, you have to be able to stand back and also look at the whole body. So, like, does gait change? Does posture change? And if the person that's treating you isn't aware of any of this, I might seek a second or third opinion, because at this point, all we're doing is we're talking about consults, right? So you kind of get your ducks in a row before you're going to spend a significant amount of time, money, and resources to do treatment with anyone.
Can I ask a question real quick? So you said active content on their website, socials, whatever. Now, there are a lot of dentists out there that have like a page on their website that talks about TMJ, TMD. And as I look at those, and they don't have any active content on social media, it's just a page on their website. Sure. And as I look at it, they like define what TMJ, TMD is. They say what can cause it. Some of them won't even say how they treat it. Some of them say they make splints. So it's very vague. And people have come to me and said, well, this dentist said they treated TMD, so I went there and everything got worse, or it just didn't help. So I guess, what do you have to say about that? Because I don't consider that active content. So I just wanted to really clarify here. Sure.
Well, I mean, we're looking at the whole breadth of the information that provider or any provider has put out into the internet, right?
Okay.
So if you look on my website, and I've got, I don't know, 3 or 4 websites at this point. If you look at my main website for just general dentistry, because I am a general dentist, there is a TMJ section, and you click on that link. There's a whole new page that pops up revolving around headaches in Oregon, TMJ, TMD type of therapy. And in there's even specific technology. So stuff that isn't traditionally found in general dentistry office, joint vibration analysis, CBCT, with airway module, so we can look at airway, EMGs, T-scan, low-level laser. Like, when you see that kind of technology in somebody's office, you're like, okay, this person is playing the TMJ game on a whole different level, right? Are those people going to be more expensive and maybe even more selective about the case selection that they choose to invite into their practice?
Right.
You have to be compliant. You have to do what we're recommending. The options are all yours, but if you're going to, pardon my French, if you're going to half-ass this thing, I really don't want to waste my time. I'm too busy. There are too many patients that want to get in and, really get down to the nitty gritty and, okay, how soon can you see me? And let's do this. Right. And then, just to take it a step further, when you talk about, you mentioned, this, having signs and symptoms maybe on a web page, I would advocate for the patient to make a list, and sometimes, patients don't really quantify where they hurt or how they hurt. So they might need a little bit of help. And, one of the things I have on my TMJ website is symptoms. And so patients can print that out. And if they haven't done it already, we give it to them. And you just circle all the symptoms you have. Or maybe you're writing down all of the symptoms that you have and hand that to the doctor. And if you get this, like, deer in the headlights look, you might be beyond that person's scope of practice. Whereas if somebody comes into my practice and there's like 48 different symptoms and they have 28, you're like, I've seen this before.
Sure.
Hundreds of times.
Sure.
Yeah, I'm ready to help you. So, those are the kinds of things that I would advocate and try to get people to, wrap their head around.
Totally. Love it.
So what's your definition of treatment success?
So, yeah, we have to put, I think it's great that we have like a very realistic conversation with patients when we're suiting up to do battle, so to speak, right? So a lot of times patients will come in and they'll say, oh, I had this one tooth taken out in my mid-30s and my bite's never been right since then. And all my symptoms started to snowball from there. Or it all started after I had a crown or a filling or whatever. And you're like, okay, well, certainly you're in the right place. If everything happened after a dental procedure, you're going to need a dentist to help you with this, right? The neurologist is not the person to go to, okay? They're good people, they're smart people, but let's kind of stay in our lane a little bit as we're guiding these patients. So a success rate of, I would say, well, first of all, let's quantify that just a bit. A success rate in the low to mid 90s is realistic. If somebody says, they're 50% successful, probably not the person to go to. If they say they're 100% successful, I've heard this from practitioners, Run, this person does not treat in the real world, or they live in their own kind of fantasy world. As good as we are, the body is so complex. So if you're somewhere in the low to mid 90s, 92, 94, something like that, that is a respectable success rate. So now, okay, well, how do you define success? Well, in my office, I define success as 50 to 75% resolution of your symptoms. Okay, so Now, there's a caveat to that in the sense that, I use the example of 48 and somebody might come in with 28 or 26 different symptoms. Well, if we cut that down to 14 or 10 symptoms, that's a win. That's a lot of things that you aren't worried about anymore. And typically what I see is, a lot of the symptoms are going to heal at different intervals, right?
Sure.
And unfortunately, you don't get to pick which symptoms heal first or heal fast. So example, we brought up the migraine patient earlier. I was listening to you guys talk before we got started. And if a patient has the 28 symptoms, they come in and the main symptom that they're wanting to focus on is their headaches and migraines. And they have other symptoms, and you take care of all of those, but you didn't put a dent in the headaches and the migraines, patient's going to perceive that as a failure, right?
Sure.
Yeah, it's not a success to them.
It's not a success to them. So, but that it also is part of the puzzle in the sense of, well, maybe this is upper cervical, referring pain into my area, right?
Mm-hmm.
So, and I think with my brand of dentistry and how occlusion, I think, is so important and so undervalued. And the more I'm doing this, the more I think the chasm is getting wider and deeper. As I do research and treat different people from all over. To that point, I think the more doctors are in this operational bubble, I'll use it and I use it as a bubble, not because we're isolated, but because in my practice, I don't do root canals. I don't place implants, don't care about them, restore them, but I don't place them.
Yeah.
Don't do so much extractions anymore. And so because this other part of my practice has gotten so busy, and so you're almost forced. It's almost like a passive specialization where you're seeing so many of these patients over and over and over. And it's great for the experience. But I think we're a lot of people that say that they treat TMJ really haven't spent a lot of time pursuing it. Like, the three of us belong to a lot of the same similar groups, like, ICMO or AACP. And so these are groups that are really focused on patients that are suffering. And I don't hold true that occlusion has no bearing on any of the oral facial pain, which there are doctors out there that believe that occlusion has nothing to do with the other. And it's interesting because those doctors will hold steadfast to that comment, but you never hear like me or Kirsten or anybody who treats with occlusion say, oh, you can't fix this without it. Well, the patient gets a vote, right? They get to what makes sense to them, which actually is a great segue to another question. As a patient, when you go into your consult and a doctor's talking to you, and you're asking your questions, whatever remedy they come up with, first of all, you should be getting a list, right, of different types of therapies or treatments. And then, what are the risks and benefits to each one of those things? Does it make sense what they're telling you as far as the treatment therapy goes? So to give you an example, when somebody comes in, I may have two technologies set up ready to go. That'd be the JVA and the T-scan. And depending on how the patient presents or what they say, my bite's off ever since I did the implant, whatever. All right, well, let's check the bite. And if the implant is high, well, it seems like it's a pretty straightforward case. Similarly, if somebody comes in and says, my bite feels pretty good, but I have clicking and popping. Okay, well, let's quantify that. We can certainly do that, and you might want to x-ray, right? So, and then going through those findings with the patient and say, yeah, you know what? Your implant actually is high. the crown is a little too high, and I'm always quick. Like, I don't want to replace anybody's stuff. Can we just adjust it and call it good? Right. And if that's the case, then yeah. And usually when that happens and it's something simple like that, people have a tendency to switch providers. And I'm not out to steal people's patients, but at the same time, if you're neglecting occlusion, I get the value that the person now has on the T-scan and that brand of dentistry, right? Does that make sense?
Mm-hmm. Yeah, but can I ask you a question about that? So because I've had a lot of patients like that too, Ben, that they're like, ever since this or ever since that was done. And when you do that, typically I've found, and maybe you don't find the same thing, but even if it's not just one tooth adjustment like of the one that was just put in for me, typically I find other interferences or things like that. So I don't want patients to think like, oh, okay, all I have to do is go back and get one tooth adjusted. Like, I find that it's a process. So I don't want people to listen to this and think like, okay, just one tooth was done. That's when my problems happened. And it's probably just needs the proper adjustment to one tooth.
Yeah, that's not how that works.
That's fair.
Yeah.
I was using a very simple example.
I know, but some people listening aren't that simple, and then they'll take every word you say at like, well, it's just one tooth.
Yeah. So, it's really interesting what we're talking about. We talk about the rock and the shoe analogy with a lot of our patients. And that seems to be a really easy analogy. So just real quick, the rock and the shoe analogy is, if I have a rock in my shoe and I can't take the shoe off, or I can't empty the rock out of the shoe, you start to walk around that noxious stimuli or the rock.
Right.
And so what happens is in the beginning, it's just kind of annoying and it's there, right? And then the longer you have the rock in the shoe, the more you start to adapt and compensate, and you start to avoid the rock. So you'll walk more on the heel or the ball of your foot. Mm-hmm. You'll walk on the outside ridge. And so there are consequences to doing that, in the sense that your ankles will start to hurt, or your calf muscles will start to hurt, on up into maybe even your knees, your hips, and maybe sometimes even the lower back. We've all seen similar things with the bite. And so in the mouth, you have 28 rocks, and it's one tooth is enough that once you start to accommodate and adapt, and that mandible starts to torque, it's just trying to find a comfortable position. Well, now teeth that weren't a problem before the implant or the high crown went in now are a problem because of the way you're compensating. So you have to treat the mouth as a whole entity, much like tuning an orchestra, right? So when you're using occlusion as your main treatment therapy, what you're really doing is making all 28 teeth work as one functional unit with two joints, all the muscles, the nerves. You're taking torque and tension out of the system, right? Which is what every orthotic should be doing, which every appliance of any kind should be doing, right? So, but to know that, you have to have, some of the technology that we were talking about earlier, and evaluate like, okay, this is how the patient walked in. This is where they are now.
Right. Have you published your findings? I know you have, but a lot of people don't. So, how do you get that even across your patients? And I would love to publish something, but I wouldn't even know the first thing of gathering the information to do that.
Sure.
I don't either.
Well, and so I am, I'm always a great resource for anybody who thinks that they want to publish. And I'll answer that question in just a second. And I got to be honest here, right? When I got out of dental school, I'm like, man, I don't want to lecture. I don't want to publish anything. Traveling. I just want to treat my patients in my own little world. And I'll do a good job, do the best job I can, and that's it. Just leave me alone, right? And what happens is, and we all do this, we all go through this probably at about year 5, year 7, you're looking back on what you were taught and you're like, man, that really doesn't work that way, right? It works how I've seen it work. And it takes a long time, unfortunately, longer than we would like, for a whole profession or industry to say, hey, let's not use X, let's use Y, right? Well, not necessarily. It didn't take us any time at all to go from analog X-rays to digital X-rays.
Sure.
It didn't take us a long time to go from a pano machine to a 3D cone beam reconstruction in your office. So look, we're not afraid to spend money as a profession, right? We're not technology aversive, right? We'll do it. What really and we'll learn new things. What really is the crux of, I think, our problem is the importance that we put on occlusion, right? It looks good. Well, just extrapolate that and imagine, what if we didn't have X-rays at all? And all we did was a clinical exam. Could you see the proximal decay?
No.
Of course not. Right. And if you were the only doctor using an X-ray, everyone around you would be like, that doctor's crazy. They're using something that nobody else uses. It's not the standard of care, right? So I started publishing because I'm looking at a patient and I'm like, I'm seeing things. I can't be the only doctor seeing this. I know I'm not. So I started doing some literature searching, and the literature's all over the place. This causes that. No, it's not related. And it's not until you're able to measure things that you're like, oh, not only is occlusion related to oral facial pain, it's the number one etiology. When you think of all the treatment that we do, and even if you don't like DTR, even if you don't want to adjust occlusion, you're going to build a night guard or some appliance or an orthotic. Well, what are you doing? You're treating the occlusion because you're putting something in between the top and the bottom teeth. Whether you like it or not, that is what you're doing. That's part of the treatment protocol, because we all know if you just went out and picked up a piece of balsa wood at Lowe's Hardware and you stuck that in between the teeth, like, that's not going to be therapeutic. The teeth are separated, but it's not going to be therapeutic, right? And we have to be careful, even when you're asking patients, okay, well, have you published any of these findings? That's like a whole nother level of intensity around the therapy of their choice, right? And it could be anything. It doesn't have to be TMD. It could be implants or cosmetics or whatever that doc's shtick is. But I think that there are people that are treating patients the same way they learned right out of dental school.
Yeah,
I think you're right.
There's a lot.
There are some good aspects to that, and there are some bad aspects to that. The good aspect is we all start at the same base level, right? And so that's good. We all have a certain level of expectation. It's bad in the sense that, okay, this person is not growing. This person is not challenging or even being aware that you've got to aware of the experience and the journey, which is practicing medicine, practicing dentistry. So if you have a, we just got through with the holidays, so this is applicable, right? If you're baking cookies, but you never add an extra tablespoon of vanilla extract, are you really that great of a baker or a master of your craft? I'd say no. If you just flip over the Nestle Toll House cookie recipe and you follow it, step A, step B, step C, and then you put the cookies in the oven at 350, then I wouldn't say that you're a master of that craft. And dentistry has a lot of problems in the sense that I think we don't have a high scientific literacy. And there's a lot of, well, this is what I do in my practice. And we have to start somewhere, and I get that. But at some point, you're like, okay, well, people are talking about tension in their face and around their eyes, in their jaw. And so, well, where does tension come from? Well, it comes from muscle. Should we measure that? If we're talking about clicking and popping in the joint, first of all, you're never going to see that on an x-ray. You're never going to see it in an MRI. Those are static images. It's going to tell you what it looks like. Okay, that's part of the puzzle. How does it function? Because the clicking and popping is always in motion. Shouldn't you be evaluating that with some technology that does that? So that's where I get, I think, some of my frustration in technology. And then, yeah, we're publishing things, and I say we, the journal is publishing things that I think has gone unrecognized for a long time. And what I find really interesting is it's only been around since 2018, which now it's 2026. And it's, as far as impact factor goes, it's like number 5 out of
That's
200
right.
different journals.
That's great.
What does that mean?
Right.
That means that other dentists are looking at that, they're publishing it, and they're using that information to not only drive what's being quoted and what's being cited, but to also treat patients, right?
I love it.
So whether you like it or not, the technology is here and dentistry is turning the corner. And the last little bit of technology that is still analog is occlusion. And
Well,
it's just a matter of time.
can you tell the listeners what journal, when you say journal, what journal you're talking
Yeah, absolutely. It's ADT&T. It's Advanced Dental Techniques and Technologies. And that is a free journal. And so I mentioned earlier that patients will go and quote me back to me, right? The journal is open access. So if you do a search on that and you're wanting to know more about DTR or sleep or orthotics, we don't just publish on DTR. Miriam Motlog published her, I think, some of her early clinical findings with her myo-aligner is in there. Full mouth reconstruction and mastication changes. Prafulla Thomati published his findings in there. And that's really a big thing. You know, to quote Radke, if the dentists don't care about mastication, then who? Right? Because I mean that's our function.
Yeah.
And so there's mastication studies that are in there, and so there's all kinds of interesting things in there that I think translate as far as making patients better and function better. But it's all open access, and the reason why we did that, there's no advertisers. This does not cost patients or other doctors money. If you really want to know what's available to you, it's there for the whole world to read. And we track that. And there's only, I don't know, there's 118 or 128 countries in the world. I think there's like only 3 countries that have not logged in and taken something from that database.
Wow.
We have readers from all over.
I love that. I love
So
that.
we talked about questions that the patient should ask the doctor when they go in their practice and their treatment and what have you. But do you recommend certain questions that the patient should ask about diagnosing and treating the specific problem? I feel like patients sometimes don't know really what to ask when it comes to like the diagnosis.
Yeah. Well, that's a great question. So, you know, I think most of us agree that a physical exam and history and even imaging of some sort is really, really good, a good baseline. The history of itself tells you a little bit, but like the social components of it, like whether you're married or whether you're single, like I watched one provider ask a bunch of questions, and she spent like 15 minutes on this person's social status, married, single, divorced, widowed, whatever. And I'm like, I don't know where she's going with this. There are plenty of people that are hurting that are single. There are plenty of people that are hurting that are married. There are plenty of people that are hurting, on and on and on.
Yeah.
I don't see that as providing the doctor with really any value to get to the end point, right? So as far as the MRI goes, I haven't ordered many of those.
Me neither. But patients
maybe like 10 and 20 years.
But people are so stuck on the MRIs and the imaging. And I'm talking not just patients, but like practitioners. Like there are some practitioners who get so stuck on all the imaging that they end up doing nothing. Like
let's go over that. Let's go over that just a minute, because when I present and when I lecture, there's a section that is on imaging, and it's okay if you want a confirmation of where the disc is, but it doesn't tell you how it functions. Does that patient have a good range of motion when they open and close? Does the jaw deviate to one side, right or left? Okay, well, whether they're functioning on the disc or off the disc and retrodiscal tissue or whatever, it's not to say that stuff's not painful. It certainly could be, but the majority of the pain comes from muscle. And muscle is a component of like 90 to 95% of the TMD cases that we do. So, whether you take an MRI or not, you still have to address that fact, right? And so things that I would like to see, and I'm probably a little different than most of our dental colleagues in the sense that before I went to dental school, I spent half a decade in research. And so data is really what I put high value on. So a lot of the things that we're talking about can be quantified, right, with numbers.
Mm-hmm.
And so, potential causes of certain aspects of TMJ or clenching or grinding is stress related. Well, not as a causative agent. No, I would say it's not. Now, that's not to say that stress doesn't take a bad situation and makes it worse. We all know that's true, right? So you could have a patient who you treated 6 months ago or 6 years ago. They show up in your office and they're like, oh my God, my symptoms are so much worse. And you just ask them, oh, well, how are things? I lost my job and went through a divorce last year. Like, okay, well, look, even if you didn't have any pain, that's enough to make you clench. So stress does have a presentation, or presents itself through the oral cavity. Sure. But what we don't see is everyone that's depressed clinically is a clencher and grinder. So can't say that this is cause and effect, right? Sleep disturbances. There's some clenching that goes on there. I don't know that I fully buy into, well, the clenching and grinding is an arousal mechanism, because in one of the chapters in the third edition of the book is, I think it was Dr. Atul in India who went and took pre and post CBCTs of DTR patients, and that airway gets larger. Okay, well, now occlusion is not just the end result. It's responsible for part of the things that we're seeing. So when you see your sleep apnea patient, if you're building a night guard or you're bringing somebody down and forward to dilate that airway, that's great, but you still haven't adjusted the occlusion. You still haven't addressed it, right? So I think that there are many layers and facets to all of this. But as far as specific diagnosis, when somebody comes in TMJ, our main thing is the T-scan, because I think the T-scan is intuitive to a patient that's having bite-related issues or even a joint-related issue. Looking at EMGs and more squiggles versus less squiggles is not really intuitive to a patient. It would be equivalent to like looking at an X-ray and see this little radiolucent area here? Well, that's the abscess. Well, I don't feel any pain. What are you talking about abscess? Well, the tooth is dead, right? But it opens a door, and I think that's a great way to help patients own their own problems and understand what it is that the doctor sees.
It definitely helps them to understand. But I know that you are wanting to talk today about a nonprofit organization that was created specifically for patients in mind, and it has 3 main goals. So if you could tell us the name of the organization, the 3 goals, what it's about, I think that the listeners are going to absolutely love what you have to say.
Sure. Well, when we started doing the journal, John, Robert, and I were all funding this through our own private money, right? With the hopes of educating other doctors, helping patients advocate for themselves. So all the research is made available. It's on the website. It doesn't cost any money. But I created the North American Institute for Digital Occlusion with the idea, as a nonprofit, with the idea of very humble beginnings, in the sense that for us to maintain the website and the journal, it's probably about $250 a month, all in, right? And over 10 years, that's like $22,000. So the purpose of the nonprofit is to use those funds to make the journal absolutely free from the people who created it as well, right? And be self-sustaining. So there's 3 main purposes or goals of NAIDO. That's the North American Institute for Digital Occlusion. We just abbreviate it NAIDO, NAIDO. And the first one is to support the journal. The second objective or goal would be for the nonprofit to support new findings with clinical research and grants to doctors who are doing that kind of work. And the third thing would be for us to have some sort of sliding scale where maybe, and I'm just throwing this out there, I have no idea what this is really going to look like, but if somebody comes in and they're like, hey, this is a person that could really benefit from DTR or whatever, but they can only afford really half of what this costs, could NAIDO pick up the other half? We've got a really good solid case here. I think this would go a long way to helping this person. Then yeah, if the funds are there, by all means, why wouldn't NAIDO step in? That's the objective of a nonprofit is to help more people. So well, how do you donate to this? Because people, I think, have the misconception of, oh, well, I'm not Elon Musk or I'm not Phil Knight and I can't just grant $1 million to this thing, right? And it's not really about that. I mean, it would be great if somebody did, or even $100,000, and I'm not having to worry about how is this thing going to support and maintain the 3 goals. But really what we're talking about is smaller donations. So I know that on my YouTube, I have over a million views. Well, what if people just put in $10 or the cost of a Starbucks coffee for one day, right? All of a sudden, there would be a ton of funding there that could do a lot of good things for people that I think are marginalized, people that I think are forgotten by medicine and dentistry, or, oh my God, that patient is back in our schedule again. Let's just put her in room 3. I'll deal with her real quick, in and out, and we'll refer to somebody else. And these patients just get passed around and they get diagnosed with God only knows what, right? Instead of somebody sitting down and saying, hey, could this be part of your problem? Well, let's hook you up to some technology. Let's see what that says. Maybe it is. Maybe it's not. Maybe I don't have your answer, right? But I think when patients are looking at tons of medication or surgery or a full mouth reconstruction, is there something simpler, especially if I'm a 28-year-old female who's been through ortho twice? I have a beautiful smile. My bite doesn't fit like it should, right? So I think that there's a number of, I think most patients would appreciate that as an option. I guess that's the best way to say it. And if people watching this, whether you're a physician, a practice provider, or even a patient, you're like, hey, this is a worthwhile goal. You can take a picture or scan that QR code, and I think there's some options there where you can either donate directly from your phone or just have it sent to your email. And I think most of the doctors that have done that have sent it to their email. And it's a 501c3 or whatever the appropriate code is for a nonprofit. We're registered in the state of Oregon. We are registered with the IRS, and we've done all our homework, and all of that is on the website for people to view because we are required to do so. But one quick take that I want to share with you guys is I came across a journal article. I was doing a literature search for something that I wanted to write and share. And one of the naysayers who calls all of this technology just gadgets, right, said that really this level of research technology needs to be in the hand of academia. Now, that was in the early 80s, okay? We're now in the mid-20s of the next millennium. And I don't see academia really taking up the reins and moving forward with that. And I don't know why. If you're going to make that claim, shouldn't you follow through? Because I as a single person, can come up with the money for it. Big academic facilities, postdoctoral facilities, dental schools, even if it was on a limited basis, could be benefiting patients and moving research forward. No one is.
Mm-hmm.
That tells you the value and importance that the profession puts on it. And I get in trouble for some of the things that I say. I'm not afraid to say them, especially when they're true.
Agreed.
So Ben, let me ask you this. A lot of people ask me, how many treatments is this going to take? And that can be a tough question to answer. So what do you usually answer when a patient asks you that?
Sure. Well, it changes. It changes from person to person because you don't know, the chronicity of their problem might play a role in it. Their genetics, their ability to heal, inflammatory response, all of that plays a role. But generally, I try to tell patients, whether we're doing an orthotic or a DTR, that it's 4 to 6 visits. And so you need to budget that time. If you think, hey, I just want to do it and I get 60% of my relief after the first or second visit and I can live like this and I'm okay. The patient puts the value on their pain and their lifestyle and all of that. I don't like leaving patients like that. Like I want it to be the best that it can.
Me too. I know it's hard.
But I always try to get them to like, hey, we're talking about 30 minutes a month. Just let me hook you up. Let me run a couple of tests. Do I need to make adjustments in the orthotic or in the DTR? And then you chances are you're going to hit a whole new level or plateau of relief. And then regardless of TMJ therapy, I think you should be monitored throughout anything else, like you're a cardiologist or you've got diabetes. Once a year, I think is reasonable to see a patient and just take the pulse, kick the tires. How are things going? Are you doing okay? Right?
Sure. Yeah. Agreed. Yeah, definitely.
I learned that from you.
I know. I love that.
Well, I appreciate the feedback, ladies. I think you guys are doing wonderful work. I love your podcast. I think people are watching this and it's reaching people. And that's the name of the game because so many people have lost hope and they're doing their own research.
I just love that you're doing this nonprofit and I think it could benefit a lot of people. So I hope that people do go out there and donate because it could turn back around and help them. So I think we should put more content out there about that too, Dr. Sutter. So why don't you and I connect at some point and then you and then Alex, we can blast it on our socials too.
Sure.
That'd be wonderful.
I'd be happy to do that. Happy.
Yeah.
So Ben, thank you so much for taking the time with us and answering a couple of the questions. And I got a question here, and I think this is perfect for you. And this patient asked, I was looking for a TMJ doctor, and the term biopsychosocial, that's in quotes, was on the website under TMJ disorder. What does this mean in relationship to TMJ, and what does it mean?
Yeah, I've asked one of the biggest proponents of the biopsychosocial paradigm that very question, and he could not define how those doctors are different than us. But as much as I can tell, and from what I've read, biopsychosocial is the idea that there's a psycho and a social component to TMD, which, okay, there's a biopsychosocial component to everything that involves a person, right? But the reason why bio is in the beginning of that term is because first you have to rule out an organic reason why a person has symptoms or having pain. And when you've ruled all that out and there's no reason why this person should be hurting, then okay, maybe it's psychosomatic or somatization disease. And so you have to start looking at the social and the psycho components of that. But really, all that is how do you live with your pain better?
Mm-hmm.
How do you accept it? And they don't measure the things that we talk about or the things that we discussed on this, right?
And they don't believe they need to be measured, a lot of them.
A lot of them think that the
it's all in your head
we use are gadgets, or it's all in your head. And your listeners that are listening to this, have you been told by a dentist or a medical doctor you just need to de-stress and take the stress out of your life?
Sure.
How do you do that?
Right.
Sign me up as soon as you figure that out.
So in other words, if you see that on a website, you might want to click to the next website.
That
in my opinion,
that would be a flag that this person or this provider does not have the technology that we use. This provider does not believe that occlusion has anything to do with oral facial pain. Those are the two big takeaways from biopsychosocial.
Oh, I love that you asked that question. Well, thanks, Dr. Sutter, for being on here. I'm going to start texting you every day like I used to. I miss you, man. And I need to get down there for my DTR.
All right. Well, you're always welcome. I appreciate you both.
So much.